Assalamu alaikum wa rahmatullahi wa barakatuh.
Not not only speaker, he is the best surgeon, best orthopedic, minimally invasive surgeon in Peshawar. And he has a lot of degrees that you can see on the website on our first lecture. And I am very thankful to Professor Salma Kundi. I would like Dr. Salma Kundi for the introduction of Dr. Shabir Awan Sahab.
Assalamu alaikum. Dr. Shabir is a very, very fine orthopedic surgeon, but he's a minimally invasive surgeon. He has specialization from the American board in minimal invasive surgery and from Canada as well, and then fellowship in laser spinal surgery. He worked as an orthopedic surgeon in Muhammad Medical College, but nowadays he's practicing privately and is an asset for KPK. Now I give it over to Dr. Shabir. The topic is backache pain and how to overcome it.
Yes, before we start today's session, I will request all the participants to mute their mics so we can listen Professor Shabir Saab smoothly, and you can ask the question at the end, and if anybody want to ask the question, raise the hand. I would like that you should avoid to ask any questions during the session, and if you want to write something on the inbox, you can also message me so that at the end we can facilitate you for the communication of Professor Shabir Saab, Shabir Awan Saab. Over to you, Professor Shabir Awan Saab.
Bismillahirrahmanirrahim. As it's my first lecture on the PMA forum, so I would like to briefly introduce myself. I am from Peshawar, and which is known as City of Flowers. I did my MBBS from Khyber Medical College, Peshawar, and after doing MBBS, I went to UK and do my FRCS from Royal College of Glasgow. After that, I was selected as a candidate for the minimally invasive spinal surgery American board among the 54 surgeons. So I did my diploma at American board in minimally invasive spinal surgery from USA. Then I did my fellowship in laser spinal surgery from United Kingdom. And as orthopedic basically is engineering and it's all mechanics, so I did the orthopedic engineering also from University of Wales. Then I was selected for the AO Spine Fellowship from Canada, Ontario, which I did with Dr. Bailey in Ontario, Canada. I have also written a book, The Pearls of Orthopedic Training, which is read all over the world and mostly in UK and America and India. And it's basically ethics about the doctor, that how you become a good doctor. There is not much clinical stuff in that book, but it is tips how to become a good doctor. I'm also a chief editor of the Ortho Bulletin, which is quarterly magazine for the orthopedic community. Now, my today topic is management of the back pain and sciatica. Back pain and sciatica topic is so long that if we can speak hours and hours, days and days, it will not end. But I will try to accumulate all these maximum and possible important stuff in just this lecture. Basically, you must have heard that if we give the example of the back, any strength or any power or any importance, we say the backbone. We give the example of the backbone. और अल्लाह ताला ने कुरान में इंजीर, जैतून, कोहतूर और शहर मक्का की कसम खाकर फरमाया, लक़द खलक़नल इंसाना फी अहसन तक़वीम, यकीनन हमने इंसान को बेहतरीन सूरत में पैदा किया। और इस बेहतरीन सूरत या बेहतरीन ढांचे का जो महवर है, जो मरकजी सतून है, वो हमारी कमर या रीढ़ की हड्डी है। इसी तरह एक हदीस का मफहूम है कि इब्न आदम के बदन की हर चीज़ को ज़मीन बोसीदा कर डालेगी सिवाय पूंछ यानी दुमची या जिसे हम कॉक्सिक्स भी कहते हैं। इसी से इंसान को बनाया गया और इसी से इंसान को दोबारा उठाया जाएगा। इसी तरह एक और हदीस कुदसी है जिसका मफहूम है कि हमने तुम्हारी कमर को ताकत अता की और इसे मजबूत किया। ये तो बातें थी सारी कुरान, हदीस कुदसी और हदीस की। शोहरा ने भी इसे जो है अपना मौज़ू सुखन बनाया और कमर जलालवी तो यहाँ तक कहने पे मजबूर हुए कि पीरी से खम नहीं कमर में है कमर, मैं झुक के ढूंढता हूँ जवानी किधर गई। बेसिकली दिस डिजेनरेटिव डिसऑर्डर, लेकिन वो ये मानने के लिए तैयार नहीं थे। आज के टॉपिक जो डिस्कस हम करेंगे उसमें इंट्रोडक्शन एंड हिस्ट्री ऑफ द बैक पेन, causes and types of the back pain, understanding through the literature, available ways of treatment, and then take home message. ये लेंथी टॉपिक्स हैं लेकिन मैंने इसको शॉर्ट किया है। So get ready and be on your toes. Low back pain. It is as common as flu in winter. It is second only to the headache as far as pain is concerned, and it is second only to the respiratory tract infection as a cause of visit to the doctor. It is as painful as piles and sometimes as crippling as stroke. 4 out of 5 adults experience it in lifetime. Can occur for no apparent reason, and surgery is not always needed. That would be my main essence of this lecture, that surgery is not needed always. It is needed, but in less than 5% of the cases. If you go back the historic review of the back pain, history goes back to the history of the mankind, and the people living in the Stone Age used to have the same pain. If you look at this screen, 50,000 years ago, if there was a back pain, they used to take the sauna bath, which is similar to the hot water bottle or heating pad as we use here in our houses or in the physiotherapy department. Then acupuncture in the new Stone Age, which is still practiced in Islamabad and other countries. It is still under practice. Then inversion therapy, which is 400 BC, they used to hang the patient upside down, and the philosophy behind this treatment was that the intervertebral disc space get increased and the pressure on the nerve which is coming out from the intervertebral foramina is reduced and relieving the pain. Then back pain therapy in the 16th century, this cruel method, from the picture it looks, but it was also in practice. And this we must have seen in the villages, our villages, that the patient who has a back pain, they ask the child to walk on the back. So this is basically originated from the 16th century. Bloodletting, that's khun nikalna. This is still practiced in Peshawar also and in other cities. And I remember that one patient, educated couple, came to my clinic and there was a dressing on the foot. And I asked, what is this? So the husband said that she is ye padhi likhi jail hai. Ye padhi likhi jail hai. She has a belief in the bloodletting. So I took her there and did the bloodletting. But I don't have any belief, so I came to you. So I said, you did wrong, because you should have come after 2-3 weeks after this bloodletting. Because if for example, with my treatment, she get better, so you will both will fight that either the cure was from the bloodletting or from my treatment. So it's still in practice. chiropractic in 19th century, and then came the osteopathy in 1892, and cupping for the back pain, जिसे हम हिजामा भी कहते हैं. This is still practiced in many cities of the Pakistan. Baba Mardan, that is one person in Mardan that who put a hot iron and he burned the skin. Yeah, as you can see here, this is the burn, and then he put a charcoal on it and do the dressing and ask the patient that your pain is gone. And definitely when you have severe pain in this area, you will forget about the back pain as a back pain theory. Yet another Pane Baba, in Pashto say Pane Baba, it is known as Pata Baba, which is he used to put the leaf on the foot and do the dressing, and it irritates, inflamed, and then get it infected, and then pus comes out of it, and he tells the patient that pus will come out, dirty fluid will come out, so do not afraid, because that all the dirt and all the pus in your leg, and it will come out and you will get better. Then surgery, laminectomy, that a big hole you can see that this is and it is basically, if you have hammer in the hand, then everything is a nail for you. So you have seen that so many ways of treatment, which means that nobody knows the exact cause of the back pain, and whoever find the cause, they start treating that thing. So it is basically still, we don't know where the pain is coming from, as our spine have a lot of structures and pain can come from anywhere. But if you suspect the disc only, I'll come later on when we review the literature, that if you suspect the disc only, so you will do the discectomy only, which is not a proper way. Causes of the back pain. Let's discuss what are the causes of the back pain. And mostly 90% of the causes of the back pain are the patient related, not a surgeon related. For over 100 and different causes, doctors rarely be able to make a diagnosis and call it non-specific low back pain, which means they have not understood the cause of the pain, that where the pain is coming from. Either it's coming from the muscle, it's coming from the nerve, it's coming from the bones, it's coming from the dura, it's coming from the nerve, from where. So they label it as low, non-specific low back pain. Most of the causes are due to lifestyle. And I always tell the patient that sciatica and back pain is not a disease. It's a lifestyle disorder which need to be addressed and which need to be corrected, and the pain will go away. It really needs doctor's help. You will see later on in my presentation that most of the causes are the patient related, so they should address it. For example, starting from this long list, I have included only few, and lack of exercise, then sedentary lifestyle, then overweight. Because if we are 1 kg overweight, the pressure on the L5S1 is 10 kg, 16 hours a day. 16 hours a day mean that when we are sitting, standing, and running, while 8 hours we are just lying. So 16 hours a day, 10 kg for 1 kg overweight. So you can imagine 10-15 kg overweight is a normal thing in our society. So you can see that if we are having 100 or 150 kg strain or stress or force on our L5S1, then you can imagine that how that disc would be. Next one is poor posture. You can see here that it's a normal posture, then it's a forward head, then thoracic kyphosis, lumbar lordosis, sway back. These are all the postures which results in the back pain. Normally, it should be straight like this, and plumb line. Plumb line mean when you put a line starting from the ear, it goes down to the ankle joint. So the over posture is one of the main cause of the back pain. If you see this gentleman, how he's sitting, if this gentleman, so they definitely they will get a back pain. Then pregnancy is a well-known cause of the back pain. Coming to the furniture, there is a strange thing, Mulazam, that there are only two things which covers our whole life: our shoes and our bed. In bed, we are 8 hours, and on our shoes, we are 16 hours. And these two things, two items or two objects are the least bothered for us. We go for the design. If there is a good design of the shoes, we take it. We don't see that it's comfortable or not. Similarly with our bed. So definitely spine will cry. Then lifting. There is a wrong way of lifting which injure the ligaments and muscles of the back, and strain will result in the pain. Then smoking is also a well-known cause of the back pain. And in America, some surgeons do not operate on the spine if there is a history of smoking. So they've asked the patient first to quit the smoking and then come back after a couple of months or maybe 6 months. Then we'll do a surgery. Otherwise, you can go to any surgeon who can do the surgery. But I will not do the surgery because the results of the surgery will not be good if you are a smoker. Then depression is the well-known cause of the back pain. It's a lengthy list. And footwear, as I said before, that we go for the fashion, we don't go for the proper as a heel. Heel is, you can see the heel here. Normally, 1.5 inch heel is acceptable. If more than that, that will put a stress on the L5S1 and result in the pain. Workplace is another reason of the back pain. So, do we doctors have any role in addressing these causes? The answer is big no, because it needs the patient's attention and willingness to address the causes. Now let's come to the causes which we can treat, are the medical causes in the spine. For example, injury that can be due to the disc, vertebra, ligaments, or joints. So we can treat that. Similarly, deformity that is congenital or post-traumatic, and disease like a cancer, HIV, TB, other diseases. Degeneration, that is spondylosis. So these are the causes which we can address and which we can help the patient. Prolonged use of the medicine like steroids, and gynecological and urological diseases. So if you compare, the 90% causes are from the lifestyle, while the 10% causes are from the medical related or the doctors related issues that we can address. Let's come to the diagnostic triage. What types of the back pain we can have? There are 4 types. Patient comes with these 4 types of the back pain to us. Number 1 is a simple back pain or lumbago. Second is nerve root pain, or we call it sciatica. Third is the serious spinal pathology. And 4th is the spinal emergency or cauda equina syndrome. So these are the 4 types which we can choose. And fortunately, the 95% patients are from this type 1, back pain or lumbago. Less than 5% are in the second category, like sciatica, and less than 1% is in these two, spina, cauda equina syndrome, and the serious spinal pathology. Simple back pain. It is axial pain, which is musculogenic or muscular pain, and mechanical in nature. And it varies with the physical activities, and it affects the lumbosacral, buttock, and thigh only. It don't go below the knee. And the common age group is between 20 and 55. In this age group, the back pain is mainly simple back pain, which is mechanical in nature. And patient is well. They don't have any other symptoms like a fever or any other symptoms. And prognosis is very good. It's 90% of the acute attacks settle within 6 weeks. And 60% of the patient has recurrence in the next 1 year. And recurrent attacks do settle in 3 to 5 years. So these recurrent attacks are also, as I mentioned before, due to our lifestyle. If our lifestyle is better, even these recurrent attacks will not come. Mechanism is a muscle strain and disc degeneration. So this simple back pain is the result of the muscle strain and disc degeneration. So you can imagine that if we receive these patients, so 95% have no neurological deficit, no neurological involvement, so we can treat it conservatively and with other methods of the lifestyle. Second, specialist referral is not required. If there is any general practitioner listening to this talk, so they should not refer this patient to the specialist, they should treat themselves. Second is the nerve root pain or sciatica. That is also called as a neurogenic pain or unilateral. It is unilateral leg pain and usually dermatomal. Peripheral or neurogenic radicular pain, as I said before, you may have the pins and needles and numbness in the same direction of the nerve which is compressed or which is irritated. There is a difference between compression and irritation. I will come later on. And radiates to the buttock, posterior thigh or foot. In first pain, simple back pain, that pain doesn't go below the knee, whereas in this case, the pain goes down to the foot. And less than, as I said before, that less than 5% of the patient comes in this category. And prognosis is reasonable if no severe deficit. 50% recover in 6 weeks. As in a simple back pain, 95% patient recover in 6 weeks, where in this case, 50% patient recover in 6 weeks. And recovery rate is slower than simple back pain, as I said. Specialist referral if not settled in 6 weeks. So if you are treating this patient and it's not settling, then you should refer this to the specialist that he should do some investigation that why this pain is not subsiding. As I said before, specialist referral not required unless signs of the severe or progressive weakness in the lower limb or reduction, red signs. Number three, third type is serious spinal pathology. That if the below the age of 20 and above the age of 55, if you have back pain patients, so you should not take it lightly, because below the age of 20, there is no mechanical back pain, but there are other causes like maybe starting scoliosis, maybe Sherman disease, maybe the spondylolysis, which is sometimes congenital, sometimes acquired. It's a breakage of the, it's a fracture due to spondylolysis. And above the age of 55, there may be carcinoma or tuberculosis or osteoporotic fracture or whatever. So in this group, if below 20 and above 55, if you receive the patient, do not take it lightly. Investigate and find the cause. And it's non-mechanical pain, meaning pain is present all the time. And mostly it is thoracic pain. In the past history of the carcinoma or steroids or HIV, you can explore in the history taking. And patient will be unwell or maybe giving the history of the weight loss. And maybe the structural deformity, as in case of the TB, a spine, or any osteoporotic fracture. But fortunately, this group is less than 5% of the patients comes in this group. Red flags. What are the red flags? If there is an infection and fever with a back pain, IV drug users, HIV, tumor or history of the cancer, history of the steroid use, and trauma such as fall or accident, and Cordova equina syndrome, in which the bowel and bladder symptoms will appear. Specialist referral is mandatory and recommended. The tests are needed to make the diagnosis, and the specialist will treat the cause, if it is cancer, or if it is osteoporotic fracture, or whatever it is. And before sending to the specialist, you advise the rest for a couple of days or until he has seen the specialist and do the investigation to rule out any cause. Number 4, the fourth type is spinal emergency. It is cauda equina syndrome, in which the bladder dysfunction, bilateral leg pain, lower extremity weakness, saddle anesthesia, poor anal tone, and maybe foot drop. If you see these signs, this is an emergency. You can't wait for, or you can't rely on the conservative treatment. You send the patient immediately to the nearest emergency or nearest orthopedic or spinal surgeon. And this cauda equina syndrome can be due to the huge prolapse disc. Normal prolapse disc may not cause this, but if there's a huge disc which put the pressure on the spinal cord and may result in the cauda equina syndrome. Second is fracture, and third is cord compression tumor. So these are the 3 causes of the cauda equina syndrome. Cauda equina syndrome is an emergency, and it is specialist consultation, immediate and urgent. Even in the middle of the night, you ask them to go to the hospital that they start treatment. It requires urgent surgical decompression. Is a primary absolute indication. It's an absolute indication for the acute surgical decompression of the lumbar disc herniation. Investigation to manage. So what are the investigation we offer to the patient coming with a back pain or sciatica? The first one is the X-rays. X-rays not on the first day, but if the patient history is more than one month or 6 weeks, so you can go for the X-ray. But here in our practice, we do the X-ray on straight away, because patient comes to us with a history of couple of months and some maybe years. So we do the X-ray first and then see if there is any information. MRI basically is highly sensitive and specific, but unfortunately there are high rates of abnormal findings on MRI in normal people. And you will be astonished to see the in the literature that, see this slide now, that in the cervical spine, 5 to 35% of disc herniation and bulge in the asymptomatic patient. It is an asymptomatic patient and did the MRI of the cervical spine or lumbar spine. And in the lumbar spine, if you see 68 to 96% of the disc degeneration and 50 to 84% of disc bulge. So here comes the point that when the patient is complaining of the back pain and saying the pain is going down the leg and there is a disc bulge, so we surgeon, we advise them for the surgery, which is not the proper way. I'll come later on in the presentation that what are the ways to treat this patient, but this is very alarming that MRI show the false positive in the asymptomatic patients over the age of 40. False positive. These are the literature full of studies saying about the fracture. Now look at this slide. If you see the imaging findings, the disc degeneration, signal loss, height loss, disc bulge, protrusion, annular fissure, facet degeneration, spondylolisthesis. So these ranges from 3% to 96%, but rather 37% to 93%. So you can imagine that, but it's unfortunate because sometimes the patient comes and they himself ask that what accident these are the names known in the community that MRI. Sometimes the patient bring the MRI with him, and I say, who advised you? So he said, Doctor Sahab, aapne karni thi, to isliye humne khud kar li. So this need to be spread, virally spread, that we should not go for the MRI, because MRI is not a diagnostic investigation. Please listen to this, that MRI is not diagnostic investigation for the back pain or sciatica. It is a planning investigation. when we decide that we are going to operate this patient, then to plan that which level we are going, which side we are going, then we do the MRI. Review of the literature and the new strategy of sciatica. If you look back previous 100 years in the last century, the first 50 years there are so many different causes and etiology existed, as we have seen in my previous slides, that there are so many causes. And in the second 50 years, second half of the century, this degeneration took over almost entire the literature about the low back pain because of this MRI, as the tendency to prefer the organic and physical abnormalities as etiology. If we see disc protrusion, we suspect the cause. If we see degeneration, we suspect the cause. If we see extrusion, we consider it as a cause. But the clinical skills are going down and down. We don't rely on the clinical skills and inclination to trust the technical diagnostic results more than our clinical judgment. Disc prolapse, I admit that there is a considerable evidence on the clinical effectiveness of the discectomy for the carefully selected patient. The stress I'm putting on the carefully selected patients, because this is the 6th or 7th method of the treatment. For initially you do the conservative treatment, and this is the selected patient with the cause of disc protrusion, which failed to resolve the conservative treatment. And understanding of the resolution of the sciatica and back pain is important. Natural recovery rates of the low back pain in the literature, it says that 80 to 90% attacks recover within 6 weeks, irrespective of the intervention. Whether you go for the surgery or if you go for the conservative treatment, it gets settled in 6 to 8 weeks. And 90% of the patient will have stopped the consulting the GP for the symptoms within 3 months. Surgical intervention versus conservative management for disc herniation. Faster recovery in the surgical intervention, but 90% of the patient treated non-operatively make the similar recovery within 2 years. Sciatica biological management. Sciatica can be managed by medication alone. These are ahead when the surgery will only be indicated for the cauda equina lesion. And selection of the case is important to avoid the adverse effect. Because if the patient doesn't need a surgery, it can be treated with the medication, with the physiotherapy, with the injection, other methods which I'll come in this presentation now. So if you go directly for the surgery, that may have the adverse effect. Pain and anatomic structures. This is important slide to understand that low back pain, that is outer annulus, these are the 4 structures from which we get the low back pain. Outer annulus fibrosus, anterior epidural tissues when inflamed, and occasionally the facet joints and the vertebral enclaves. So we get the back pain from low back pain from these structures. And buttock pain we get from the annulus and compressed nerve roots simultaneously. Whereas sciatica, compressed, stretched, or inflamed nerve. So these are 3 things. Either it's compressed, or it is stretched, or it is inflamed. Then we get the sciatica. And early patches of sciatica like knee, heel pain is inflamed nerve. 8 ways of treatment. So there are the 8 ways of treatment to address the low back pain and sciatica. First, as I said before, do nothing. It will settle in a couple of days or maybe in weeks, but you don't need any treatment at all. I'll come in the later on to elaborate this. Second is medicine. Third is physical therapy. Fourth is spinal injection. Fifth is minimally invasive spinal surgery. Sixth is microdiscectomy. Seventh is laminectomy and discectomy. and 8 is spinal fusion. If you see patient around you, mostly patient, they come under this 7th treatment, laminectomy and discectomy. Because as I said earlier in the presentation, that if you have a hammer in the hand, you do nothing. Just need assurance to the patient that it will get better on its own and continue the normal activities. No need of rest, because rest is death and moment is life. If you do the rest, your muscle will get more weak and more wasted. So rest is not recommended for the back pain. If you can't move, that is not rest, that is disability. Then we go on the 2nd and 3rd treatment. But doing the rest just in a sake that I'll do the rest and my back pain will get better, it is not true. If you move, it will get better. Pain hurts, but it's not harmful. For the muscle, it say use it or lose it. If you use the muscle, it will develop. If you don't use it, it will get wasted. Second is medication. And medication also, do not start from the day one. If you, in a couple of days, 2-3 days, if you feel the pain is not settling down, or if pain is more, you can take straight away the painkiller. But if you feel the pain is not much and you can move around, to try the first method. And if you feel that it's a pain is not getting better, or 2-3 days gone and pain is still there, then you can take the medication like paracetamol, muscle relaxant, non-steroidal anti-inflammatory drugs, and lacosamide or gabapentin. These doctors can recommend you. This is when the pain is not only in the back, but when going down the legs, then we can add this also. Physical therapy. Physical therapy, there are so many modalities in the physical therapy, but main thing is the manual manipulation of the joints and addressing the trigger points. Mostly the patient prefer these machines, that shortwave diathermy and ultrasonic and mega infrared and all these things. But basically, the treatment which gives benefit to the patient is to release the trigger points. Injection therapy. People think that injection is dangerous, but no, it's not. It is, you can give the injection in the facet joint, steroids, or with the local anesthesia. And nerve root injection, there are 4 types of injection you can use. This facet joint injection, if you see on the X-ray or CT scan or MRI that there's a degeneration in the facet joint, you can give that. For the nerve root injection, if not responding to the conservative treatment.
समझ नहीं आ रही
क्या समझ नहीं आ रही?
From where you are not from where you are missing, can you
nerve root
I think it's
injection.
the volume.
उर्दू बोले, समझ नहीं आ रही, उर्दू बोले.
अच्छा, उर्दू बोले.
Are you not hearing properly?
Okay. No, he say that it's not in Urdu. That's what he's saying. That is the presentation is not in Urdu, so that's why he is not able to understand. So
क्या मैम कह रहे हैं, उर्दू बोले.
अच्छा. So these 4 injections, that facet joint injection, nerve root injection, epidural injection, and intradiscal injection. Now in intradiscal injection, now they also putting the ozone also. Ozone and stem cell therapy. I'll come later on this, but this is the 4th way of the treatment. Then acupuncture also, I have put in the injection as it's needles and still used in the Islamabad and other countries. Minimally invasive spinal surgery. This is me here. This was long ago in Innsbruck doing the minimally invasive spinal surgery, and the advantages of the minimal invasive spinal surgery is that the patient is awake.
Please English, no Urdu.
Awake and Mulazim, can you please stop his speaker, please, microphone, please. Awake and aware state surgery with the precise targeting of the pain generators. So patient is awake. The difference between the minimal invasive spinal surgery and the conventional surgery is that the patient is awake and you can communicate with the patient that, and when the patient touches, the surgeon touches the nerve and the pain results, we can ask the patient that, is it the same pain which you feeling? He say yes or no. Then we touch another disc, another disc. So to find out the exact location of the pain generation, then we address that. Similarly, in the here in many hospitals, they do under general anesthesia, which is wrong. It should be under awake and aware state, that you can communicate with the patient to locate where the pain is coming from. And it is reduced surgical, even we don't stitch the wound, it's because it's just like a needle and a small cannula. Increased effectiveness at the target and increased interaction during the surgery with the patient, and reduced cost and mobility. This is the method that you can go with the needle, and then you can put the trocar, the cannula, and so you can see easily that it is very, very minimally invasive, and it is there, even no stitch is needed.
Hello, assalamu alaikum.
Sixth method is micro discectomy. With the help of microscope and under general anesthesia, they do the discectomy. And seventh, decompression and laminectomy and discectomy. As I said before, that this should be tried when all other methods fails. Conservative and minimally invasive fails, then you can go for this method. Decompression and fixation is the last way of treatment, where you can fix the spine with the intervertebral disc also, or cage, or these are different methods you can fix the spine. But this is the last method. These are the references that I have collected from to prepare this disc.
Thank you so much.
Sir, the take-home message. The take-home message left. Take-home message is that nobody knows the exact cause of the back pain yet. The ways of treatment confirms lack of understanding. In addition to the various treatment modalities, yet another one, which is stem cell and ozone treatment, is emerging that have to be proven yet. It is already get practiced in Islamabad and in Lahore and Karachi, but that also need to be proven. Still, there is a need to explore more in understanding and bring the standard ways of treatment and agreeable to all. Just suspecting the 2 Ds, that disc and degeneration, because up till now and in the last 50 years, we are suspecting these 2 Ds, disc and degeneration. So doing discectomy and fixation is not the solution. 90% patient can be treated non-surgically, and up to 97 or 93% MRI scan findings are false positive. So time will come when the surgery will only be for the cauda equina syndrome. If the conservative measures fails, the best option is minimal invasive spinal surgery. Thank you very much.
Thank you very much. Very beautiful slide at the end. बहुत शुक्रिया आपका. आपको कुछ लोगों ने उर्दू में पूछने का वो किया.
मैं जवाब दे देता हूँ, आप सवाल करें.
Now you can ask the question in Urdu. अपना कैसर साहब, मुझे 1 मिनट, एक उर्दू के 2-4 सवाल हैं, उसके बाद मैं आपकी तरफ आता हूँ. जी उमैर मलिक साहब, यू कैन आप सवाल पूछें, आप कोई पूछना चाहें तो. जी पूछें, आप सवाल कोई पूछना चाहते हैं उर्दू में. ओके ओके जी कैसर सजाद साहब, आप पूछें आप सवाल. कैसर सजाद साहब.
Thank you very much, Mulazim Saab. It was really a wonderful and excellent presentation by Shabir Awan Saab. and I'm really amazed. Because I'm also suffering, Dr. Shabir, I'm also suffering from the backache, and in my student life, I am a retired person. I have retired from one of the Sarkari hospital in 2018, and now I am doing a private attached with a private medical college. But in my student life, I had one or two motorbike accident, and I had a backache from very beginning, maybe because of the wrong posture of surgeries. Mastoid, we do mastoid. We assist mastoid to our professors, our seniors, with bending with bending position, because I am 6 feet height, but my senior professor had a short actually, yeah, exactly. So I have to bend down and putting water on the mastoid drilling. So for a longer period, I did all this. Then finally, I had a severe numbness in 2015 in December. Or then I consulted कि what happened. I thought कि ये कोई जो कभी कभार गलत पोजीशन में सोते में कुछ हो जाता है, but it was not that. Then I got the MRI done, and it shows that a huge prolapsed disc. So it decided to go for the surgery. I had my class fellow here, the उसका क्या नाम है, उसने बहरहाल
don't take the name, it's
okay. So he advised me to go for the surgery, and it is decided day after tomorrow मेरी surgery हो जाएगी. But suddenly one my colleague advised me कि don't go for the surgery. Then after that, in PMA office in Karachi, a few UK and from America, few colleagues, our friends came, and they have a different opinion. The majority was in favor that you don't go for the surgery, you just go for the conservative treatment. But I did not have a severe pain, or pain rather you can say, in my backache, but I only have a numbness on my left leg. Till the finger was not, still my finger is not so much active, or I mean it's moving, but numbness is there. So I didn't have the surgery, and I'm what you have said. You are absolutely right that I was not in a single time I lie down on my bed. I have not taking any rest, and I'm doing my routine work, my private clinics and everything, and all my PMA activities. Sometime I had a pain, sometime I don't have pain, but I'm doing everything. So, but from last to last Sunday, I was watching India and Bangladesh match, and in the evening, and then on sofa, and I was so much relaxed, and I put my leg on the stools in front of me. So during this watching, I slept, and I just receive a telephone and wake up, and I can't stand up. I said, what happened? It's over. So gradually I wake up and take water, and gradually I just take a Neurol tablet, and it is gradually better, but still I have pain, and I thought that I am disabled, that I cannot, but I am not taking any holiday, any chutti or any rest. I am doing my work with hi hui or kamar mein haath rakh liya. Lekin I have 2-3 days physiotherapy also, and with their advice. I am also doing the exercises, following all the physiotherapist advice. So this is all about. And my question is, should we now? Okay. I had an MRI repeat on 2018. So the neurologist said that now it is fibrosed, no need to surgery, just go ऐसी जिंदगी गुजारो. तो मैं फिर ऐसे ही चलता रहा हूँ और अभी कुछ भी नहीं करता, लेकिन मैं काम वाम करता रहता हूँ. तो my question is के should I consider or should I take advice for surgery? Number one. Why this is so much difference between the, as you also mentioned, surgical and conservative? And your point, what I understand, that you are in favor of more percentage to conservative as compared to the surgical. Or if surgical, then it should be MIS.
सवाल को मुख्तसर करें क्योंकि so many hands are raised. जी.
Okay. So this is my question. कि ये क्या है और मुझे क्या करना चाहिए? This is my question. What I have to do.
The first answer is that you should do the regular exercises. You have, as I have heard from your story, you are doing everything, but you are not doing the proper exercises. Number one. Number two, ask your physiotherapist to find the trigger points in your muscles, that where are the trigger points, and they will release manually. So you will get better and then continue regular exercises.
वो मेरी दवाइयों इसमें सफेद थैला है.
Then other thing is that you say that you need an MRI or not. No, you don't need any MRI at all, and you just need regular exercises. Once you do the exercises, your muscle will get toned and your pain will be relieved. And the second question was that why there's a difference. So it's a difference of opinion that some people suspect that this is the cause and some people suspect this is the cause. So it is, I can't comment on that, why the people are more on the surgery or why people are more on the conservative. Yes, next question, please.
One thing I would like to ask.
Yes.
I used to do a brisk work from the last many years. मैं सुबह 5:30 बजे उठता हूँ और मैं उसको तो should I continue brisk work?
Yes, brisk work you should continue, and then you can take my number from the Salma or Mulazim. I can send you the proper exercises, and we can discuss with each other, inshallah. Okay, and everybody, all the participants are requested that they can take my number and they can call me anytime for any advice.
We'll share your number. Dr. Shafaq is a professor of gynecology in Muzaffarabad. She is asking something about the posture. She has also commented on the inbox. Can you, Dr. Shafaq, what do you mean by question about the posture? Dr.
She has asked about the. Walaikum Assalam.
I was just asking that first option, you said that if you have a low backache, you should do nothing. You can opt for that option. So should we advise the patient, because as a gynecologist, we encountered many patients for low backache, and many of them we don't, especially the antenatal patients, we only counsel them. But the aged ones who are not antenatal patient, they come and with low backache or simple low backache. Usually, I don't refer them at the first place. I advise them to take postural, to keep their back straight and don't lie in the different positions. That's what I was asking. My question was with you that for these old aged ladies or middle aged ladies, those are not pregnant. What they who have just started the low back pain in do nothing. You gave one option, do nothing. What counseling would we do for them?
Yes, I got your point. Yes, I got your point. The first antenatal, you are talking about antenatal, you should advise all the patient with antenatal condition that they should do the pelvic floor exercises and the core spinal exercise that your physiotherapist will tell them. So whenever you see any patient, you just refer them to the physiotherapist just for the exercises, not for the treatment, because there is a dilemma that if you refer the patient to the physiotherapist, they ask him to come daily, which is not good. So their antenatal patient need the pelvic floor exercises plus spinal core exercises. This is your part one question. Second is the old lady who are not pregnant. They, as I addressed before, that if they are overweight, they should reduce the weight. They should have the proper bed, proper shoes. So you can counsel them on these lines. And in addition to the simple exercises, you can tell them whether it's antenatal or postnatal or non-gynecologic, non-obstetric patients. So you can address them, treat them like this.
Thank you very much. Now the question, Dr. Shafaq, it is enough. It is enough question.
Yes,
Are you
yes,
satisfied?
thank you, sir. Thank you so much.
Okay, okay,
Yes.
Professor Shafaq. Now the Professor Sarwar Pirkani from Balochistan.
जी प्रोफेसर साहब,
जी
What is your question?
Pirkani, क्या पिशावर में भी बलोचिस्तान में भी बैकेक होता है?
बहुत होता है जी, बहुत होता है ये हमारा जी।
Assalamu alaikum from Quetta, Dr. Sarwar Pirkani. Are you listening, sir?
Yes, we are listening.
Yeah, my story is mimicking with the Professor Kaisar Saab. I am also retired but working again. But one complaint is that if I sleep in the bed in the morning, it looks like that I have not took rest, but I was traveled so many distances. So when I wake up, I feel pain in my buttocks and lower upper thigh. So I don't know, is it the reason due to the bed or the sleeping?
Yes, there are two reasons. One reason is your mattress may be old than 5 or 6 or 7 year old mattress, which is giving you this trouble, number one. Number two, your sleep, maybe you are sleeping late night and getting early, so your sleep is not proper. So these two things. Number three, by the face you look that you are a little bit overweight. Am I right?
Yeah, it's a little bit. Yes, you are right, sir. You diagnosed from the face.
Little bit. So, yeah, little bit. So check your mattress and the timing of the sleep. And start some, as Dr. Saab said, when you go for the morning walk,
when I tried to sleep on the ground, it was then feeling very hard when getting up to stand up if I'm on the floor. So I shifted to the bed. But I think which type of this mattress should be?
Mattress should not be that orthopedic mattress or this mattress and that. These are all commercial things. These are all the commercial things, because you need a firm mattress which is not old than 5 or 6 year old. And then what trick you can do, every first day of the month, you change the mattress head upside and upside down, and then right to left and left to right. So for example, on this first September or 1st October, you just change the mattress position. For example, the head and you put it and put to the footrest and foot to so that will give the more life to the mattress. And similarly, you can put the left side right and right side to the left. So that will give you the more life to the mattress. So this is the mattress reason. Lying on the floor is not recommended.
Thank you so much. Professor Zubairi साहब, मैं आपकी तरफ आता हूँ, but I think Professor Muhammad W. Khan, sir, you can ask the question, Dr. Muhammad Khan.
Yes, please.
जी Dr. Khan साहब, जी Professor
Zubairi is also asking.
Okay, Tanveer Zubairi साहब, you can ask the question before
yes,
Dr.
please.
Khan. जी, Professor Tanveer Zubairi is the professor of radiology and very senior teacher. जी, Professor Tanveer Zubairi साहब. प्रोफेसर मेरा मुझे लगता है कि आज टीचर कम है और मरीज ज्यादा हैं। जी जी ज़ुबैरी साहब।
हाँ जी, अस्सलाम वालेकुम।
जी वालेकुम
सलाम।
अस्सलाम। जी जी तनवीर ज़ुबैरी जी। हाँ हाँ आ रही है, आवाज आ रही है आपकी।
Yeah, can you give me Awan sir, can you hear me? Excuse me, hello.
जी
जी
सर।
हेलो हेलो
Can you
हेलो।
hear me?
जी जी, yeah, I can hear you. Yes. Yeah, we can hear you.
First of all, I want to thank Dr. Shabir Awan for such a wonderful talk, and what in a brief period of time he has explained a very difficult topic, and I fully endorse and agree with him. We, in spite of all of our advancements in the medical science, we are still unable to find the exact cause of the back pain. Uh, and being a radiologist, I can fully endorse his findings, and we do agree that we overdiagnose the cause of.
Dr. Tanveer, your voice is breaking. Okay, can you write your message? Can you write the message? Professor Khan, you can ask the question. Professor Khan.
जी सर, अस्सलाम वालेकुम वरहमतुल्लाहि वबरकातुहू।
वालेकुम अस्सलाम।
Masa al khair. This is past 12 p.m. now.
Thank
Ji,
you.
first of all, I'm very grateful to the organizers,
Thank you
Mulazim,
so much,
Professor
Dr.
Mulazim
Khan.
Hussain Bukhari, and Dr. Salma.
Yeah, sorry. Hello,
Awesome
excuse
job.
me. Awan sir.
जी जी, सुन रहा हूँ मैं जी।
Yes, 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 you can ask.
Excuse
जी
me.
Mr. Khan sir, continue Dr. Khan.
Ji, I'm very grateful to my Awan family brother, the guest speaker, the honorable guest speaker. I am sailing in the same boat as Dr. Kaisar Sajjad. I happen to be a consultant ENT surgeon, so I'll not repeat the problem. We all ENT surgeons have the same problem. But kindly, I would like to ask my honorable speaker to give us more time, because I can fully endorse that so many people, so many departments, including the gynae obs also, they would like you to present separate, such clinical presentation for each and every department of the medical faculty. Sir, my short question.
I'm totally willing to come to your colleges, to your hospitals, and give a lecture. No problem at all.
Very kind of you. May Almighty Allah bless you.
Dr. Awan Sahab, next time I will request Dr. Tanveer Zubairi, because he is a radiologist. I will request gynecologist and few other peoples who are the stakeholders in the back
panel. Yeah. Yes.
And we will, inshallah, this is a very beautiful topic, and मेरा ख्याल है कि हमने इसको थोड़ा सा मजीद पब्लिकली करेंगे, और इसको हम हो सकता है कि उर्दू में ही करें, बिकॉज बहुत सारे लोग जो है इसको उर्दू में डिफिकल्ट फील करते हैं. Dr. Tanveer Zubairi, you can complete your comment.
Yes. Yeah, actually, I couldn't. My connection was lost as I was just traveling. My observation was I just wanted to thank, and which I sent my compliments to Dr. Awan. Second question, what I have got is that these new modalities like MR and others, they have some of the neurosurgeons, they have started making fortune out of it, and I've seen so many of unwanted laminectomies being performed every day in and day out. So my question is that I was for quite some time doctor to the Pakistani teams, Pakistani football team and Pakistani hockey team, while I was young in my 30s and 40s. So I remember sending some of the patients with the post-traumatic herniations and others to Apollo Hospital in Delhi. And I had some contacts over there, because when I went to US and other places for my training in sports medicine at that time, so this microscopic discectomy was being performed over there, and it was being introduced over there, but no one in Pakistan was performing it. But some of the surgeons which returned from US or Europe were performing it in Apollo hospitals in Bombay and Delhi. So I remember sending a few sportsmen over there. But still, in Pakistan, I really don't find much of this neurosurgeon performing microscopic discectomy because it is minimally invasive, and I believe it has got good results. So I just wanted to have your take on this modality, and is a good number of neurosurgeons available back home in Pakistan who can perform this, as I believe it has got lesser morbidity and less complications, post-op complications.
Yes, you are right. Actually, you should go one step further. Instead of microdiscectomy, now there is an endoscopic discectomy, which is performed under the local anesthesia, and it is not used as a microscope is not used. Its endoscope is used, and the patient is awake. And in microdiscectomy, patient is under general anesthesia, so you can save him from the general anesthesia also. Secondly, you can communicate with the patient during the surgery. That's endoscopic spinal surgery. That is done in many centers in Pakistan now. The second question is, you ask about the back pain, and I can tell everybody, those who don't have the time for the exercise, if you those who are watching me, if you pull your tummy inside, the belly button, for example, I'm sitting like this, and if I pull my belly button in, those who are saying that, doctor, the ENT surgeon, that I was long surgery, so they just make a habit of pulling the tummy button inside, so your spine is jacked up by 1 inch or less than 1 inch. So if there is any pressure on the nerve, that is reduced, number one. Number two, your core spinal muscle get exercised by that. So if we make a habit, even I say them to my patient, that we do minimum 32 times qiyam in our prayers, 5-time prayers. So if we are standing in the qiyam and you pull the belly button inside like this, those who can watch me, if I'm standing like this, instead you do like this, pull the belly button in. So your abdominal muscle, which are basically the corset, natural corset. हम जो कमरबंद बांधते हैं, तो कमरबंद जो है, तो natural corset is abdominal muscle. If your abdominal muscles are strong, your back pain will be relieved. So coming back to the question also, that yes, this is minimum spine surgery is good, but again, surgery is needed only by 5% of the patients, not 95% of the patients. If you see the disc bulge and you advise them the minimal new surgery, this is not good.
Thank you, Doctor. If there is one question, Dr. Shahid Awan Sahab, does vitamin D insufficiency or deficiency aggravates the backache? By Dr.
Yes, I have answered in the chat. Yes, it aggravates. Yes.
Yes, Dr. Mahadev Hirani, can you ask the question, Dr. Mahadev? Dr. Mahadev Hirani, can you ask the question?
Sir Mulazim, if you allow, I am Dr. Muhammad Waqar. Can I complete my comments and question, because I was cut short by the communication?
Yes, please.
No problem.
Yes, please.
Sir, my request to the honorable speaker would be to guide us kindly that in my case and Dr. Kaisar Sajad's case, we are a known patient of back problem. What is the gold standard test? Gold standard test for our follow-up. Radiological test. First test,
no,
follow-up. For follow-up,
no, the clinical examination.
What is the gold standard?
No, clinical examination is the gold standard to diagnose.
Okay, thank you so much. And what can be the gold standard for any nerve involvement to detect whether there is investigation to detect
clinical examination. Clinical examination. You can find the dermatome, you can find the myotome, you can see the strength, you can see the movement. So once you suspect that, for example, L5S1 or L4L5 or whatever is suspected, then you can go for the MRI to see that how much pressure is there. But there is another condition which is called chemical sciatica. Chemical sciatica is that where there is no disc bulge, but there is irritation to the nerve. Irritation to the nerve that results in the sciatic pain. So that can be treated by the medicine. And if it's, because I have seen so many patients that they have normal MRI, but they still have the pain during the going down the leg. So that's that is known as non-compressive or chemical sciatica. So you can treat it with the medicine.
EMG investigations like EMG, do they help? Electromyography.
Yes, they do help. But then, if when you have detected that there is a deficit, grade 3, grade 4, power is less, so then you can go for EMG and see that what is the grade of that weakness, or what is the grade of that nerve damage. Yes, you can go for the EMG and nerve conduction studies. Yes.
Okay, thank you so much. Almighty Allah bless you. Almighty Allah bless you. Thank you so much.
Thank you so much.
Let's wind it up quickly because we've already taken his time. Shabir, the question that I have is, there are many people who are suffering from disc prolapses. How do we prevent that?
As I said, the lifestyle. Disc prolapse comes when you put a pressure on the disc. When you put a pressure on the disc, it will prolapse. So if you have the your core muscles are strong, and if your weight is optimal, then you don't have the disc prolapse at all.
So everything boils down to a nice weight.
Lifestyle. Yes, lifestyle.
And lifestyle.
Okay.
Well.
Yes.
Okay. Can I ask one thing, Dr. Shabir?
Yes, please.
I have a 4 or 5 prolapse disc. I have already mentioned you on the left side, but this time I had a pain. Still, I have a pain on my right side. And what is this? When sometime on my right groin, it feels like a cutting pain sometime. So was it is referred something? What the cutting type pain? What it indicates? Number one. And number two, I am doing my exercise and everything, but somebody told me you don't pray your namaz with normal posture. Is it true, or I can pray my namaz?
It's not true. The symptom you are telling me might be the femoral nerve that is coming from the front, and it might be there's irritation, and it sometimes comes and sometimes goes. So you should follow the proper prayer, not in the chair or not in the sitting on the ground. And I guarantee everyone that if you follow the prayer according to the Sunnah, you will not have the back pain at all. You will not have the back pain at all.
Okay.
Yeah.
But I'm not doing proper ruku.
Ruku should be very stretched. As much as you can go down it will give the more stretch to the muscle. If you look at my hand, you are doing like this and coming back. Doing that. Yeah. So if you initially try to go as much as in couple of days, you will be able to go like this. This helps in stretching your back muscles. If you are all the time doing like this, so these muscles get stiff and they don't get the strength. Similarly, you must have noticed that in the Fajr prayer, as Qiyam is very lengthy, so when you go down to the Raku after Qiyam, you feel back pain, and that is because of the stiffness. Because of stiffness. In other prayers, you don't feel any pain during going down to the Raku, because in that prayers the Qiyam is not lengthy. So that indicates. That's why I said that when you are in Qiyam, try to pull your belly button inside. So you will get the muscle stretch, and when you go into the Raku, you will not feel the pain.
Thank you so much.
Good. Thank you very much. What about the cutting pain which I mentioned?
That is neurogenic. It's irritation of the nerve. Irritation of the nerve, when it is irritated, that get the cutting or burning sensation. Yes.
Is it not serious, I hope?
No, it's not serious.
Okay. God bless you. Thank you very much, Dr. Shabir.
Thank you.
Dr. Shabir, I think there are so many other questions, but we are cutting short.
And Mulazim Sir, please. I am extremely thankful to my president. She was my president, Dr. Salma Kundi. She has selected Dr. Shabir Awan. Shabir Awan sir for this, for today's presentation. I must thankful to Dr. Salma Kundi. Thank you very much, madam.
Professor Salma Kundi, I would like to ask you to conclude today's session.
Thank you so much. Thank you. Dear Dr. Shabir, I'm so indebted to you. I'm so grateful to you. You've spent a few hours this Sunday with us, and we hope to hear more good things from you, how to take care of our spines and our bones, inshallah ta'ala, and hope to meet you soon. And it was a great talk. We learned a lot. Allah bless you for that. Thank you so very much. And I thank all the participants for taking the time out on Sunday. Have a blessed day and a blessed weekend. Allah Hafiz.
Allah Hafiz. Meet you next time, inshallah.
Thank you so much. Thank you very much. Thank you.
Allah Hafiz.
Allah Hafiz.
Thank you. Allah Hafiz. Khuda Hafiz.